Great. So my talk is going to be on immunotherapy for prostate cancer. And we know immunotherapy is different in this disease than we see in other diseases such as bladder cancer, lung cancer. You can see dramatic objective responses with bladder cancer. In fact, about a quarter of patients, as we talked about the other day, will show objective responses. Prostate cancer is different. We do see survival benefits with treatment, but we do not generally see PSA declines or objective responses. And the reason is we think that there may be an activation of the immune system that takes a period of time, particularly with vaccine therapy, and may not be initially evident when a patient receives treatment. So this is a summary of what we see with PSA changes by Dr. Madan from the NCI. And with immunotherapy, we see that there can be a blunting of the PSA curve as compared to what we see with cytotoxic therapy, where there's a decline and the slope then returns to where it was prior to starting treatment. There are FDA-approved agents for immunotherapy in prostate cancer for all patients who are asymptomatic, have bone disease, and do not have visceral metastases. Sipuleucel T is approved. This is an agent that is basically taken from the patient's own immune cells. They go through apheresis where their lymphocytes are removed. They're exposed to prostatic acid phosphatase, and then the antigens will then be presented to the dendritic cells. They're then activated and then reinfused back into the patient. This is done for a total of 3 times. The IMPACT trial demonstrated a survival benefit in favor of Sipuleucel T compared to placebo in asymptomatic patients. And these are patients who could have had prior chemotherapy. In fact, 15% of the patients did have prior chemotherapy prior to entering on study. And the median survival was 25.8 months for those patients who received CIP-T. The hazard ratio was 0.775. So the question is, what are the right patients to administer this type of treatment to? There have been studies that have looked at the volume of disease as measured by PSA, and in fact, if you break up by quartiles from the original from the original 3 studies that were performed with CIP-T, we'll see that those patients of a PSA of less than 22 have the best difference in median survival, about 13 months compared to placebo. We see that also reflected in the hazard ratio. Again, the same thing with the PSA of 22 to 50, but the higher PSAs, we don't generally see a benefit. So are there other confirmations of this initial data? The answer is yes. This is a trial that Dave Quinn and I ran looking at Sipuleucel T combined with enzalutamide, either given concomitantly or sequentially. And we looked at time to events at 36 months, also PSA progression-free survival. And we found that there was really no difference between sequential or concomitant administration of enzalutamide. We also looked at the quartiles, and we found that there was a better survival, like in the same situation before, based upon PSA quartiles. So the patients who did best were the ones who had the low PSAs, less than 3.9, and then as we move up let me just move over to the next slide. As we move up the different PSA values, we start seeing that the hazard ratios actually become less significant or worse. So the survival outcomes, it doesn't matter whether you give Sipuleucel T or enzalutamide concomitantly or sequentially, but we do see that the same quartile pattern that we saw with the original CIP-T studies. The other important thing to remember is that even though you may not see a difference in survival, there are other parameters that are important. This is a paper that I published a number of years ago looking at pain-free survival and at 12 months, and there actually is a difference in CIP-T versus control, and that's also most evident for those patients who received narcotic analgesics. So again, there are other parameters aside from PSA that help us look at this particular treatment. This is an update of some data that came out this year. Prosvac, it's a vaccine treatment that has been administered in patients with prostate cancer. It's basically a 3-pronged vaccine comprised of a PSA antigen and then 3 costimulatory molecules, LFA3, ICAM, and B7-1. The bottom line was that we saw an improvement in overall survival in a randomized phase 2 study that was published by Phil Kantoff. A larger phase 3 trial was presented earlier this year comparing Prosvac plus GM-CSF, Prosvac alone, or a placebo. And unfortunately, you could basically superimpose these survival curves pretty well. There's no difference in overall survival. So they concluded that there was no difference in survival. It did not confirm the phase 2 data. And unfortunately, as a single agent, Prosvac is not moving forward. Now, we saw some interesting data in bladder cancer with PD-L1. This is a huge controversy in prostate cancer. You may have seen the New York Times article where they talked about administering PD-L1 to patients more as a desperation treatment. But we know that this immune target is expressed in hormone-sensitive prostate cancer specimens. It may be at a higher rate than the naive, the refractory specimens. It's upregulated by enzalutamide, and there have been some trials combining the two of these together. But the level of PD-L1 expression is generally low. It's about 15% in all patients. Now, the important thing to remember, and I'm going to talk to this is, I think, something we all should be looking for, is something called mismatch repair or microsatellite instability. There's one drug that is approved by the FDA across all tumor types. That's pembrolizumab. And this drug is, of course, a PD-1 inhibitor. And it shows an improvement in survival in patients who have mismatch repair, irrespective of their tumor type. About 2 to 3% of metastatic castrate-resistant prostate cancer specimens will have mismatch repair. So we should be looking for this in all of our patients through next-generation sequencing, because if this is present, you can see a dramatic response. So there was a patient in this particular trial who had mismatch repair, and he did have a significant response. I've got a couple of patients like this as well with large bulky pelvic disease who've seen responses. Mark Garnick at this meeting has also talked about patients just like this from his practice. Again, you have to look for it. If you're not going to look for it, you're not going to see it. And I think that since the responses can be so dramatic, if you don't, it's really not doing the patient justice. Atezolizumab, a PD-L1 inhibitor, has been evaluated, and this is some data that our group presented last year at the ASCO GU meeting. We're currently preparing the manuscript for publication. And we had one extremely good responder in our study. And as we see here, as time went on, this patient developed infiltration of his tumor with CD8 cells. And interestingly, his PD-L1 expression was negative initially when he started. But unfortunately, as I said before, the majority of patients did not respond to atezolizumab. We had two had major PSA responses, but unfortunately, again, not what you would expect to see with bladder cancer. This patient that had the dramatic response was microsatellite stable. He did have a DNA repair mutation. And this is a theme with immune therapy in prostate cancer. The patients right now who tend to respond have DNA repair mutations. Pembrolizumab has been evaluated in this disease. This is a publication of the University of Oregon where they found that there were 3 patients, about a 10% response rate, who had dramatic responses to pembrolizumab. Interestingly, there were responses in liver, which was something that was not seen with ipilimumab, another checkpoint inhibitor in a previous trial. Johan de Bono actually presented this data at ASCO this year, and what he did was he took 5 different cohorts of patients with castrate-resistant prostate cancer, treated them with pembrolizumab. Some of these patients had PD-L1 expression. It was just basically combinations of PD-L1 expression and measurable disease. And then he had a cohort who had received prior enzalutamide, and they had either measurable disease or bone mets and no measurable disease. This is cohorts 4 and 5. These are, again, the typical castrate-resistant prostate cancer patients. The median PSAs are about 300. About half of these patients in the first 2 cohorts had visceral disease, only 12% in the bone metastases cohort. And we did see, again, some responses with this particular treatment. Again, it's about the 10% range. But when we look ahead, let me just move to this before we wrap up. The patients who tended to have the responses were those who were BRCA positive or ATM, and that's where that was really driving the overall response rate. High rate of PSA responders, 11%, other DDR genes, 10%, and those who did not have the DDR mutations, it was only 3%. So again, I think that this is something that may be a way of stratifying our patients in the future. So in conclusion, Sipuleucel T improves survival in men with castrate-resistant prostate cancer. And based upon the quartiles data, I believe that immunotherapy should be given early in the course of castrate-resistant disease. PSA declines may not be seen in patients treated with immunotherapy, but they still may benefit. And in my opinion, all patients who have castrate-resistant prostate cancer should have their tissue tested for microsatellite instability.